This PowerPoint is going to cover nutritional problems. When it comes to poor nutrition, people really have an increased nutritional need, which is ironic because when you're sick, many times you do not feel like eating, so you have a decreased actual appetite. Poor nutrition is usually a common consequence of illness, surgery, injury, hospitalization. Many things can cause people to have poor nutrition. Diagnostic studies that help us kind of find that whether they're having nutrition imbalances is like a food history for the past week, height, weight, vital signs, and a physical examination. Malnutrition is a deficit, excess, or imbalance of the essential components of a balanced diet. Of note, this can include undernutrition and overnutrition. A lot of people think of undernutrition, but overnutrition actually counts as malnutrition. Undernutrition occurs when the nutrient reserves are depleted and nutrient and energy intake are not sufficient to meet daily needs or added metabolic stress. Overnutrition refers to the ingestion of more food than is required for body needs, such as obesity. There are 3 causes of adult malnutrition: starvation-related malnutrition, chronic disease related to malnutrition, and acute disease or injury related to malnutrition. There are many contributing factors that can really cause the development of malnutrition. This could be socioeconomic status. Are they poor and do not have access to food? Cultural influence. Is there a specific diet that their culture kind of guides them to that leads to an imbalance of, say, things such as iron or different kind of ideas? Physiological disorders. Are they paraplegic or quadriplegic that they cannot feed themselves? Medical conditions. There are many kind of medical conditions that can lead to malnutrition. I like our little man here in this picture who does not have any teeth or dentation. So how is he supposed to chew his food? And then food-drug interactions. Are they taking some prescription medicines that are decreasing their appetite or are causing them to not want to eat? A lot of this can be such as chemo, things like that. Laboratory studies. The serum albumin is really not a great indicator of acute changes in nutritional status. This is more of a long-term deficit. Usually the value lags behind actual protein changes by greater than 2 weeks. So really this is not going to tell us short-term, it's going to tell us long-term deficits. Then there is prealbumin. The prealbumin indicates the current state. There is the CRP, the C-reactive protein, which indicates inflammation, tells if there's any kind of infection or any issues. Electrolyte levels. One of the big ones is potassium levels, really often increase in poor nutrition, and sometimes it even can decrease depending on what state of malnutrition they're in. Their CBC, their red blood cell count, hemoglobin, lymphocyte count, that's really going to help us as well. And then also a reminder that liver enzyme levels may be increased during malnutrition. There are many kind of high caloric supplements that we can first offer patients. The first step that we always do is we try to get patients to take things orally. You don't want to just jump to the IV stuff unless you have severe malnutrition. You want to start orally because it's kind of the conservative way to start. You want to encourage clients to increase overall intakes of calories, but not just empty calories. You want proteins, vitamins, minerals. You really don't want to just have them push to eat whatever they want. You want specific high calorie supplements can really be used too and should not be used as meal substitutes. Instead, they should be used as in between meal snacks. So people who just drink an Ensure for their lunch, that's not going to be as effective as a patient who eats lunch and then has Ensure at 2 p.m. and then eats dinner. If oral nutrition does not work, we can move to the second option, which is enteral nutrition, and parenteral nutrition are the next steps. So enteral nutrition is really when patients can't take any or enough oral nourishment. This is also known as tube feeding. Administration of nutritionally balanced liquid, food, or formula through tube inserted into either the stomach, the duodenum, or the jejunum. This is important, must have a functioning GI tract for this method to work. So think tube feeding. I'm still giving them nutrition that their abdominal or their GI system is going to absorb. So it really has to be a functioning GI system. Um, Advantages, they provide nutrients alone or as a supplement to oral or parenteral nutrition. Easily administered, safer than parenteral, which we'll talk later, which is the IV nutrition. More physiologically efficient than parenteral and less expensive. That's a big one. So there's a couple of methods that you can use for tube feeding. This is a continuous infusion by pump. Intermittent by gravity. Some people prefer the gravity because it's the body's natural way of absorbing it. Intermittent bolus by syringe. Cyclic feedings by infusion pump. Most of these, the continuous infusion usually is used with like our most critically ill patients hospitalized. Intermittent feeding can be used for patients receiving feedings at home. A great example of this would be a patient who is maybe on chemo, having trouble getting their nutrition, so they give themselves a little bolus 5-6 times a day, and that helps with their nutrition status. Common feeding site locations. Really, it is called where the actual, or like the tube is called where the tube ends up in the anatomy and physiology. So you have the nasogastric. This is a temporary tubing, so this one goes through the nose and into the stomach. This is also what we use, and this can be complicated for bowel obstructions or anything that we want to pull out of. So you want to, when you have an NG tube, you want to think, is things going into the body or things coming out of the body? So when we're using it for nutrition, it goes in through the nose into the stomach. You can also use what's called an OG tube or an oral gastric tube. This is temporary as well. We see this a lot with our intubated patients because they already have a tube through their throat. So you just pass that OG through as well. Then you have a G tube, which goes directly into the stomach, and a J tube, which goes directly into the jejunum. So the jejunum is lower, you can see in the pictures. Both the G and J tube are surgically inserted. NG tube, most common for short-term feeding problems. If they're going to need feeding tubes for an extended time, that's when we would usually consider a J tube, G tube, which goes directly in. NG tube inserted directly through the nasal cavity is radiopaque, and you have a decreased likelihood of regurgitation and aspiration when placed in the intestine. The problem with these is they can be easily dislodged by vomiting or coughing, and they become knotted and kinked into the GI tract if they're for long terms. So it is due to kind of a smaller diameter. It can be clogged with thick feedings. It is also more difficult to check residual volumes, and especially like to obstruct when oral drugs have not been crushed or dissolved in water before administration. This is true for both tubes, but especially in G tubes. So you really want to make sure to crush those drugs well and flush. You really want to flush tubings after both drug administration and checking gastric residual volumes, or GRV. Those can clog your tubings. We'll talk a little bit about gastric residual volume, but I think what's left over in the stomach. It used to be a common practice, especially that every time you would wait a certain amount of time and check your GRV, and if there was a large amount, that means that they're not absorbing that. G tubes and J tubes, these can be used for extended periods of time. They have to have an intact, unobstructed GI tract. They can be placed surgically, radiologically, and endoscopically. A very common tube that's used is called a PEG tube. It's percutaneous endoscopic gastrostomy tube. It's used usually placed by using endoscopy. A gastrostomy tube is inserted through the esophagus into the stomach, then pulled through a stab wound made in the abdominal wall. The retention disc and bumper secure the tube, usually no need for general anesthesia, and client is minimally sedated, if at all. So if a patient has issues with sedation or we have any kind of concerns, a PEG tube is a great option. So once they get a tube, feedings can be started when bowel sounds are present, usually 24 hours after placement, especially if they had any kind of sedation. Immediately after insertion, tube length from insertion site to distal end should be measured and recorded. Especially this is important with NG tubes. Is their NG tube at 65? Oh no, now I'm rechecking it 24 hours later. Now it's at 45, which tells me that the tube has come out. So tube length is extremely important, not just to look and pass on to your next nurse. It is important to document. Safety issues, especially for enteral nutrition administration. You really want to position patient with head of bed greater than 30 to 45 degrees. You really want to flush the tubing to maintain patency. You want to monitor for any kind of aspiration. And then use sterile liquids or formula with closed systems, really not wanting to put infectious liquids into the body. And then we're going to monitor nutrition status and the tolerance, and that's where the GFR comes in. Enteral tube patency. You really want to irrigate with 30 mils of tap water before and after each feeding, drug administration, and after residual volume checks. You want to be careful for patients with any kind of like congested heart failure where you don't want to add, or kidney issues that you don't want to add extra fluid to the body. But in general, you'll have an order that says flush this amount this time. If you don't have an order, 30 mils is the way to go. Continuous feedings must be administered on a feeding pup with an occlusion alarm that's going to tell you, hey, this is not being pushed in. You want to check the placement before each feeding and drug administration, or every 8 hours with continuous feeding. You want to mark the exit side of the feeding tube at the time of initial x-ray. So sometimes take a Sharpie and put it at the NG tube mark is a great example. And observe for a change in the external tube length during feedings. Please don't get lazy about this. This is how people get aspiration pneumonia and have any different kind of complications. Checking the placement, there's the auscultation, which is when you, this is a big one for NG tubes. Usually with the J tubes and G tubes, you don't really need to check the placement. You just need to look at the insertion site and look at the measurement. If you're going to physically check the placement, you can do auscultation, which is where you put a little air in your syringe. You put on a stethoscope, you put it over the stomach site, and you push that air in, and you should hear this nice little whoosh sound of the air being moved into. If you don't hear it, don't panic. Try a couple of times. A way that they used to check for placement site is the aspiration of stomach content. So you would aspirate a little stomach content and check the pH. A pH greater than 5 usually was indicative that it was in the stomach. Not as accurate anymore, especially with people with GERD or different kind of like reflux where the acid could be higher. So the most accurate assessment that most hospitals are going to is x-ray every time. Used to be that you could just auscultate and that would count as your placement check, but a lot of hospitals are just going to x-ray to check. You don't have to do an x-ray every time you're going to use the feeding. You can auscultate after you know it's in place. So first time I put the NG tube in, I get an x-ray. If it's 2 days later and I want to make sure my placement still sounds good, I'm going to use auscultation. Big safety issue is checking for gastric residual volumes. This is also known as GRVs during the first 48 hours for gastric fed clients. If let's just imagine all of a sudden I'm putting, different, I guess, nutritional fluid in there. I'm giving that tube feeding and I'm not checking my gastric residual volumes. And it turns out that the patient actually isn't tolerating them. They're just sitting with that massive amount of input that we're placing into their stomach, and then all of a sudden they vomit it out and cause aspiration. So that really is a huge safety issue. So especially the first 48 hours, but we're going to watch for it otherwise. because if they have any kind of gastric emptying that is delayed, this can cause issues. This is kind of an example of the formula that is preferred. Usually it's liquid, sterile. It used to be powdered or reconstituted formula, but now they've really gone to the liquid sterile. This has a less chance of bacteria, which means less likely of infection in the patient. Usually the formulas are specific to a client's health problems, whether it's a renal formula, a cardiac formula, a diabetic formula. There's different kind of formulas out there. Formulas really are reconstituted in advance. They should be immediately refrigerated and labeled with date and time and discarded within 24 hours after preparation. That's why it's important to put the date and time. When a client is started on the nutrition, full strength isotonic commercial formula is preferred for initial feeding. That's going to be the ones that we want to make sure they can tolerate that. A lot of the other formulas can be a high risk of diarrhea from microbial contamination. Really, you want it to have it at room temp. If it's in the fridge and it's cold, it can make the stomach very upset. So you want to get it out of the refrigerator 30 minutes before feeding. When you're administering these feedings, you have a couple options. The pump, which gradually increases rate over a certain amount of time, usually 24 to 48 hours, depending on how they're tolerating it. You should have specific orders for that. There's intermittent feedings, and the volume usually 200 to 500 mils of feeding. So let's say a patient has a new tube, you might start with the first intermittent feeding of 200 mils and work our way up. And again, water flushes and boluses as tolerated. A lot of doctors will put in a specific order for how much fluid to really bolus to keep the patient safe. Disposable gum or gloves are recommended during administration, and a blue pad or towel also used because it can be messy, especially when you're learning and you're first doing it and you're trying to give a tube feeding. It's important to kind of have a pad down. Great example of this is, let's say you have a PEG tube and you're trying to do a little intermittent feeding and the patient coughs all of a sudden. It can cause a backflow of abdominal pressure, which causes the tube feeding to come back out through the PEG tube, and it can make a really big mess. Other nursing considerations that we generally use with these patients: daily weights. We want to assess bowel sounds before feedings, accurate intake and output. So this is very important to say exactly how many mils intake they have, and watching for output. Glucose checks, especially in diabetic patients, but we usually do it with all patients. Daily or labeling with date and time that the medication is started, because this is very important. You must change the tubing every 24 hours. I'm going to say that again because it is usually on some kind of test question. A pump tubing must be changed within 24 hours due to infection rates. So this is very important that you label the tubing. If you walk in and you notice that the tubing is not labeled, there's no documentation, it is recommended that you go ahead and change to the tubing. Complications, aspiration we talked about, vomiting can occur, especially with stomach upset, especially if you give them cold nutrition. Diarrhea happens quite a bit, especially with an elderly population. The nutrition that they're given isn't the most digestible at times, so it can cause diarrhea. It can also cause constipation and dehydration. They're more caloric dense and less water formula, so the flushes are extremely important for hydration, and you also want to check for high protein content. Skin. We want to watch for those kind of potential problems, and skin irritation at the tube site is a big one. So you want to check around that tube site, especially if it's a J tube, PEG tube, or G tube. The protective ointment that you could put around it, zinc oxide or petroleum gauze, or a actual skin barrier that is created, that usually is like in your supply Pyxis. Big one that you want to be careful for is a misconnection of the tube or patient pulling out the tube. I have once seen a patient pull out a peg tube, and that was not a fun experience. So you really want to watch for it. Are they delirious? Do I need to teach them about this? If they are like a dementia patient, do we need to even put them in restraint so they don't pull out their tube? And then with misconnections, really you want to make sure you're going into a feeding system. Most lines are completely different, so you can't connect an IV fluid tubing into a peg tubing or a peg tubing into the IV fluid, but you really want to be careful of where you're connecting your tubes. Um, Geological considerations. So with our elderly population, they're more vulnerable to complications, especially fluid and electrolyte imbalances, glucose intolerance, decreased ability to handle large volumes, and increased risk of aspiration. The third type of nutrition you can use is parenteral nutrition. This is administration of nutrients by the route other than the GI tract. So if you remember the other options, you need a working GI tract. This is using the bloodstream to provide nutrients. It's usually used when GI tract cannot be used for ingestion, digestion, or absorption of essential nutrients. The goal is to meet the nutritional needs and allow growth of new body tissue. This is usually using regular IV solutions. The big one that we use a lot is dextrose in water or dextrose in LR. There's no protein and usually about 170 calories per liter. Just think dextrose equals sugar. A normal adult requires minimum of 1,200 to 1,500 calories per day. Regular dextrose solutions could exceed capacity of the central venous system. Usually the people that need more kind of nutrition is any kind of injury, surgery, burns is a big one, malnutrition or malnourishment, and all increased nutritional needs of patients. Another big one is cancer patients or people who are on chemo that need the higher calories, but they are so nauseous, or sometimes their cancer is of the esophagus or something where they do not like to eat. Common indications: chronic or intractable diarrhea and vomiting, complicated surgery or trauma, GI obstruction, GI tract abnormalities, and maybe a fistula, and malnutrition. The composition, base solutions contain dextrose and protein in the form of amino acid. There is prescribed electrolytes, vitamins, and trace elements that are added to customize. So a lot of providers will go in and specifically add specific electrolytes and so on, usually with the help of a dietitian, to really specify what kind of nutrition this specific patient needs. There's also IV fat emulsion that's added to complete the nutrients. Calories are supplied by carbs in the form of dextrose, fat in the form of fat emulsion, up to 30% of total calories from fat, and less fat concentrations for those critically ill patients. It's becoming more common to administer lipid-free parenteral nutrition for the first 3 to 5 days of a critical illness due to the potential for omega-6 fatty acids to produce pro-inflammatory mediators that can make this patient worse in that critical illness. Protein, usually 45 to 65 grams daily. Requirements are increased in nutritionally depleted patients to ensure a positive nitrogen balance. Electrolytes, usually individual requirements are assessed, and trace elements and vitamins, usually zinc, copper, chromium, magnesium, selenium, and other multivitamins are added into that solution. Methods of administration, there's 2 types. Central parenteral nutrition is used for long-term support. Peripheral parenteral nutrition is used for short-term therapy or special conditions. So this is a central or a PICC line used for that TPN. You can see that this one, or the one on the far left, it goes in through the chest. The one in the middle, it goes in through the arm. Usually a PICC is a peripherally inserted central catheter that is a very popular route for short-term solution as well. Something to know about the central parenteral nutrition is the catheter tip lies in the superior vena cava, which is actually the heart. This is indicated when long-term support is necessary or when the client has increased protein or caloric requirements. Usually you can use subclavian or jugular veins. You'll hear this as subclavian or IJ. Then there's the option of peripheral inserted central catheters and long-term parenteral support. All of these are at high risk for what we call CLABSI, especially the one that lies within the heart trips. This is a central line associated bacterial systemic infection. That CLABSI has to be reported to state, so there's lots of different interventions that are required to prevent those central line infections, but the biggest goal is to get the central line out as soon as possible. But if you think about it, if you're putting nutrition in through a central line, the nutrition already is at high risk for bacterial growth. Then we're adding it straight into the heart, so definitely a high risk. Peripheral parenteral nutrition, this is through peripherally inserted catheter or vascular access sites. Never in the hand. You do not want to put any kind of nutrition in through the hand. This is short-term support. Most places are moving towards only letting midlines, is what they're called. They're not quite PICCs, so they don't go through into the heart, but they're midlines, so they go a little bit further. But they're not quite as long as the PICCs. This is short-term support, protein and caloric requirements not as high, and supplement inadequate oral intake. Usually peripheral mixes have lower glucose content than the central mixes, and the amount of glucose in the peripheral system can cause significant fluid shift because it's not going straight into that heart. We have to monitor that IV site very, very closely because those sites can go bad very quickly. That's why you do not want the small veins like in the hand, and you want to be checking your line to make sure it is flushed and accessed well. So this is a look at TPN or total parenteral nutrition, and lipids is another one. Usually you give either both together or just TPN or just lipids. This is an example of extravasation of an IV site. So you can see the redness. It's very, very painful for patients. This is a IV site gone bad. So this is an IV site gone bad to the extreme of getting that nutrition underneath that skin. Parenteral nutrition solutions are prepared by pharmacist or trained technician under strict aseptic techniques. They must be refrigerated until 30 minutes before use. So usually a tech or a pharmacist will walk that solution straight up to the nurse and hand it to them. They have to be labeled with nutrient content, all additives, time mixed, and date and time of expiration. This is also usually a dual cosign, so it takes two nurses to cosign together to start the solution, and you must check the order with the label on the bag, specifically all the nutrients that are put in. Refeeding syndrome, this is usually due to long-standing malnutrition states, fluid retention and electrolyte imbalances, and hypophosphatemia, which is decreased phosphate level, is the hallmark. Normal range is usually 2.4 to 4.4. Those who are at increased risk of refeeding syndrome are usually those with like chronic alcoholism, vomiting and diarrhea, chemotherapy, or major surgeries. So again, you'll see that fluid retention, electrolyte imbalances, usually hypo for phosphate, potassium, and magnesium, and hyperglycemia. So think low electrolytes, high sugars. Usually the signs of hypophosphatemia are cardiac dysrhythmias, respiratory arrest, and neurological disturbances. Refeeding syndrome can occur at any time in malnourished patients, and it started as that is started on a aggressive nutritional support. Their body can't handle it. So the goal is that I was talking about earlier of starting at a lower calorie density for 3 to 5 days. This is to try to prevent that refeeding syndrome. Fluid overload is a big complication. High volume of fluid introduced into the system. This can cause significant problems for patients who cannot get rid of excess fluid. Big ones, CHF, congested heart failure, and kidney failure. Congested heart failure because their heart can't pump the fluid through, so it tends to back up into the body. And kidney failure because their bodies cannot excrete that fluid. This is one of my favorite pictures that shows fluid volume excess. Really, the big thing you want to know that is a priority problem is watching lung sounds closely. I'm going to say that again. Any kind of crackles usually means that there's some kind of fluid overload or fluid volume excess. Another one is dependent pitting edema, which is important to watch, but think lungs over edema, right? If their lungs are already crackly and they're not being able to have oxygen exchange, that is a big issue. So some more complications of parenteral nutrition is metabolic problems. Usually you can see some hyperglycemia, some hypoglycemia, prerenal azotemia, which is the presence of nitrogen waste products in the blood, especially urea, due to decreased blood flow to the kidneys. You can also see fatty acid deficiency, electrolyte disturbances, hyperlipidemia, mineral deficiencies, anything like that. This is usually because patients have a difficulty adjusting to the amount of nutrients being infused. If they're not used to getting that kind of nutrients, their body is going to really kind of be freaked out by it and trying to adjust. Labs are drawn at least every 24 hours to verify the patient's overall nutritional levels and the patient's ability to metabolize the mixtures. You can also have mechanical problems, IV site problems, dislodgement, thrombus of a great vein, and phlebitis. So this is an example of a thrombus. As you can see in this picture, the vein, there's a large blood clot, and that inflammation and clot is due to trauma of the vein. So this can be a big risk of pain. It can also cause different clotting issues. So this is something to be watching out for. This is an example of phlebitis. There's a little red streak that might be hard to see, but it's going up the patient's vein. This is irritation and inflammation along the lining of the vein. Phlebitis can readily occur in the vein as a result of hypertonic infusion and can also be a sign that leads to infection. So something to watch out for. This might be a sign that you need a new line. Nursing management. So really we want vital signs done every 4 to 8 hours. We want daily weights because that body weight is considered the sum of the changes of protein, fat, and water. So on a daily basis, body water fluctuates more than protein or fat. Really, we want analysis that must be really whether gain or losses in weight are caused by fluid gain from edema, fluid loss through diuresis, or actual increase and decrease of issues or like tissue weight. So daily weights are a good sign. We want to track it, but sometimes it's not as accurate. Blood glucose. Some increase in blood glucose level is expected for the first few days because really we're seeing we're introducing more sugar than what they're used to, so their body's trying to compensate. Goal, really, our glucose range is 140 to 180, and then this will level out after a while. Electrolytes, we're going to check their CMP, their BMP, BUN, and creatinine, which is going to tell us kidney function, and the CBC. So we're going to check liver enzymes as well. We're also going to constantly be watching those IV dressing changes and watch those site observations. Really, that's the key to catching inflammation and infiltration, especially with these people that may be immunocompromised and are susceptible to like opportunistic infections. We're going to watch out for refeeding syndrome. And then infusion pump must be used. We need to periodically check volume infused to make sure it's actually actually infusing the correct amount, but you don't want to be not watching your infusion amount going in. So before we administer, we need to check the label and ingredients against the order, like I was talking about earlier, with another nurse. And then we're also going to examine the bag for any signs of contamination. This could include leaks, color changes, particulate matter, clarity, fat emulsion cracking. This is where it's good to have maybe a more experienced nurse when you are starting out that knows what to look for. It's always the nurse's responsibility to ensure that the solution is de-seeded and replaced with a new solution if the bag is not empty within the end of 24 hours. Tubing and bag must be changed in 24 hours. So if you are getting towards the end of the bag, it's important for us to make sure that we're not emptying out the entire bag if it's been over 24 hours, because that puts them at a risk for infection. So we're really watching for infection and septicemia. Infection is more of a local, septicemia is more of a systemic. So local manifestations, we're really looking for arrhythmia. This could be some redness around the site, tenderness, and exudate at the catheter insertion site. Systemic, this is a bigger deal because it's more throughout the entire body. You're going to see fever, chills, nausea, vomiting, malaise, fatigue, and then you're going to see some vital sign changes, maybe an increased heart rate, increased respiratory rate, lower blood pressure. Those are the last signs of really a patient being septic. So if you do have a sign of infection, if it's just a localized infection, you are going to just remove that catheter source. You might not need antibiotics because usually the removal of the catheter can eliminate the problem. If they have a long-term catheter like a central line, midline PICC, you usually will save the catheter tip when you DC the catheter. So you want blood cultures drawn, and then when you pull that catheter from the body, you are not going to let the catheter touch anything. You are going to cut the tip off and put it in a specimen cup and send it to lab, and lab is going to culture that. X-ray, you really want to, like daily x-rays, if not a little bit more often, to check for changes in pulmonary status. And then after parenteral nutrition therapy, daily dressing changes until the area heals. One question people ask a lot is, when can we discontinue this parenteral nutrition? And the general rule is 60% of caloric needs should be met orally before we discontinue these parenteral nutrition or even enteral nutrition. Some people will need to go home with this nutritional support. This takes a lot of education from the client and the caregiver. Usually you want the caregiver to come in and you both sit down and change out the bag, talk about how to do these home nutrition. This could include catheter or tube care, mixing and handling solutions and tubing, and the side infection complication that they should be using or like monitoring for. These home nutrition therapies are expensive. For patients to be reimbursed for expenses, there needs to be specific criteria that's met. So the discharge planning team needs to be involved early in the mission to help plan for such issues. This takes a lot of people and a lot of education, and you want to send them home with the right tools. A lot of home health companies too will meet them at home and help with these kind of nutrition, like long-term nutritional patients, if you can get home health ordered or covered by their insurance.